Okay. So good morning, friends. Welcome back to Saturday Club of Baroda meeting. And today we have with us Dr. Hiren Bhatt, who is a consultant plastic surgeon in Vadodara. And he has been our guest speaker in past also, when the meetings were held offline and even online. He has a vast experience in practice since 1991. He is deputy editor of International Journal of Aesthetic Surgery. His education affiliated Plastic Surgery Education Foundation Trust USA, project director Smile Train Program USA at KGP Children Hospital, Vadodara since many years. He's member of American Society of Plastic Surgeons, Association of Plastic Surgeons of India, and Indian Association of Aesthetic Plastic Surgeons. Currently, he is affiliated with his own setup as Director Aesthetic Surgery, Navya Aesthetics, Vadodara. Today, he will be talking about newer technologies and adjuvants in wound healing. Few weeks back, we had a wonderful talk on skin banking, and that sort of inspired us to have a talk on wound healing from none other than Dr. Hiren Bhatt, who is a very well-known plastic and aesthetic surgeon in Vadodara. So welcome, Hiren. Once again, thank you for joining us. Now the stage is yours for 40-45 minutes, and we'll have some 10 minutes or 15 minutes of discussion. So over to you. Thank you.
Thank you, Sadiq Bhai, for the opportunity as well as for an introduction. A lot of science has gone for. Can you see the screen?
Yes. There is a message for some Zoom. US is requesting to bypass the system. Okay. Yeah.
Basically, whenever there is a wound, there is a discontinuity of epidermis or epithelium, and we have to restore it. And the complex process of wound healing can be uh, summarized into one thing, that ultimate aim is to achieve a skin continuity. Now, most of the time, wound healing is a problem in terms of chronic wounds, and there are many.
Even your voice is cracking. I mean, we are not able to hear it clearly. Jagdish bhai, are you able to hear him well, or it's okay? Anybody else who can? Yes?
Now it is better.
Yes, better.
Okay.
So we have many modalities in treating the chronic wounds, and we will be going through all these options available, like negative pressure wound therapy, dermal substitutes, skin substitutes, and their mechanism of actions and their cost benefit analysis. So basically, chronic wounds have been identified as wounds that do not heal for more than 3 months. And most of the time, we have four common conditions like diabetic ulcers or diabetic foot, as they are known to. That is primarily because of the poor circulation and nerve damage. Then venous leg ulcers due to poor venous outflow and prolonged congestions, which lead to delayed healing. And pressure sores due to lack of immobility, pressure on the skin, and uh, subsequent necrosis of the tissues in the arterial also are responsible for non-healing wounds, and they are primarily responsible for conditions such as atherosclerosis or in good old days the Tau disease or something like that. Risk factor to these primary four conditions are age and obesity. As one goes above, the arteries already get clearer, the blood supply also reduces, and obesity is a ubiquitous negative risk factor for most of the conditions, lifestyle diseases. Immobility, sometimes it becomes a vicious cycle. The person develops ulcer, it reduces mobility, that subsequently lead to congestion, and it can lead to further healing issues. smoking and tobacco habit is a very prevalent, and when there is a healing issue, the smoking and tobacco consumption leads to poor capillary circulation, and this can lead to further problem with the healings. Now, the challenges include infection management, which inhibits the healing, and the blood supply. Poor blood supply reduces to decrease oxygen, decrease supply of nutrients and antibiotics to the wound bed. We also need to remove the necrotic tissue removal. Negative pressure wound therapy, NPWT, or is also known as VAC, that is vacuum assisted closure, is a very old system which is now become available in India for last 10 years. And it's a very good tool in the hand of surgeons treating the wound infection. Now, basic principle of the vacuum assisted closure or NPWT is to provide a controlled environment. Uh, Customer made wound according to the size of the wound. A foam is placed. It is sealed, and with the help of a non-written valve, it is connected to the machine. This provides a controlled environment. The sealed wound does not get any infection from outside. The continuous negative pressure, which can be adjusted between 25 to 175 mm of Hg, can be used to customize according to the condition of the wound, condition of the skin of the patient, condition of the general condition of the patient, and the ultimate result is to improve and the blood flow. The negative pressure will lead to reduction in interstitial pressure. It will improve the capillary circulation.
Yeah.
Hmm? Hello?
Sorry, Hiren, please continue.
Okay. It will improve the venous return, arterial blood supply because of the negative pressure, and that will lead to uh, stimulation of wound healing. The form that is available will promote the granulation tissue formation by fibroblast margillation. To improve circulation will bring antibiotic and antibodies to the wound, and a very early result in the form of formation of a healthy granulation tissue can be seen. The vacuum around the wound promotes healing by drawing out the fluids and encouraging the fluid. It reduces the time, it decreases the infection, improves the patient comfort. With the system on, patient can be mobile also. Doesn't have to be even in hospital. The therapy can be considered at home also. The device, as I said, applies constant negative pressure. There, and there are possibilities of adjusting it in various cycles, like negative pressure for a while and then for few minutes, no negative pressure. All this is decided according to the condition of the wound and according to the general condition of the patient. At cellular level, it stimulates fibroblast and induces neoangiogenesis. The complication or risk of the system includes skin maceration. Surrounding skin, if the vacuum applied is too much, can lead to a maceration. And if in case of, say, diabetic patient, this can be another potential source of infection. So we have to be very careful. Then there is a risk of bleeding, especially patients are on anticoagulant or antiplatelet agent. This negative pressure can draw a lot of blood from the capillaries, and a significant bleeding can happen. So we have to ensure before starting the therapy that patient is off such treatment, and for if required, we need to consult the primary physician or the cardiologist to evaluate the patient about being fit for starting this treatment. Some patients do develop a lot of pain in the initial phase of vacuum application, but they get adjusted to this in about 6 to 8 hours. So we need to keep the patient under supervision in hospital or nursing home for about 6 to 8 hours till the pain is controlled. Later on, the pressure needs to be monitored. If there is a leakage, the system will not work. If there is excessive pressure, then also system will create problem. So what happens is we need to educate the patient's relative or the nurse looking after the system to read the alarm and to provide the necessary feedback to the treating doctor or the technician. Currently, the company provides the technicians which can be easily contacted in case of such alarms by the patients or patient's relative, and they also pay on-site visits if required. Venous ulcers is one of the common. We can see this kind of situation wherein there is no development of granulation tissue despite using all kind of dressing materials. Even culture sensitivity and antibiotic given to this doesn't lead to improvement in wound bed. With the help of application of negative pressure therapy, is the kind of a foam dressing filled with the uh, sealing material available along with the this foam, and a valve is connected, which is connected to this system. And in about 2 3 days time, we can drain about 400 of interstitial fluid. Once the edema resolves, the granulation tissue, as is in here, is covers the wound bed completely, and then we have to do the skin grafting. We can also do the mesh skin graft and apply the negative pressure over it. Another indication for WAC is a pressure sore. Here is a case of recurrent pressure sore, non-healing for 7 months. A WAC dressing was applied, and within about 4 5 days, there is complete granulation, red granulation covering the braid. This can be covered with a flap, or even in this small case of in this case of small pressure ulcer, we can do primary closure also. Larger sores require flap surgery. So preliminarily, we have to do debridement and then apply the wet dressing. Once the red granulation tissue covered, we apply the flap. After applying the flap, we use again the wax system for the drainage of the wound. This will reduce the edema in the surrounding tissue. It will also remove the collection that is developing under the flap and improve the viability of the flap. This is a case of diabetic foot with poor granulation tissue and slough seen. After debridement, wax was applied, and day 8, as we can see, the complete healing is there. We applied the match skin graft, we applied the wet dressing over it, and within 5 days, it would heal. Dermal substitutes, as they are called popularly, are essentially regenerative matrix. Uh, they are biomatrices which they provide a substitute of dermis kind of thing. The primary aim of this is to improve the vascularity, improve the penetration of granulation tissue through the matrix, and provide a scaffold for wound healing. They also facilitate the tissue growth inside, especially used for the wound which are full thickness in nature. Based on their properties, they are classified as permanent or temporary. They can be biological, synthetic, or mixed. They can be cellular or acellular. They can be immunogenic or non-immunogenic. There are biological cellular like cultured epithelial autografts. They are basically skin substitute. The cultured skin substitute, composite cultured skin, all these. Biological acellular substitutes include cadaveric allograft, the skin banking thing. Biological acellular also includes xenograft. We provide a collagen elastic matrix like Metridum. Metridum is a known brand. Synthetic include polyurethane foam with silicone sheet over it, like Novosob biological temporizing matrix. Other mix of synthetic and cellular include Epicel or cell epigraph. They are not available in India. And there are collagen glycosaminoglycan matrix, which is known as Integra, which is now available in India. The dermal matrix provide uh, elastic collagen matrix, which allows improvement in wound healing by allowing cell invasion, cell proliferation, neoangiogenesis, devascularization. Myofibroblast formation is reduced. As a result of this, the contractures and scar contractures will be improved. And because of that, the possibility of poor scar, possibility of contracture will reduce remarkably. These are essentially open torrent matrix made of collagen fibers. There is no chemical cross-linking. It contains elastin in between. And this kind of network allows permeation of the vessels and nutrient fluid. The elastin fiber component improves the vascularization and improves the elasticity of the new skin. They also allow early physiotherapy and rehabilitation. The collagen fiber permits improved healing by cell migration and reconstruction of the new dermis. And there is no chemical cross-linking. There is no release of cell toxic substance or no allergic reaction to these materials. The procedure is a one-step procedure wherein we apply after debridement of the wound, and the patient later on can go home with the subsequent follow-up for the dressing. Uh, there are also situations wherein we need two-step procedures. Here, what happens because of large surface area or deep wound surface, or when the wound is exposed with tendons or bones, we have to first feel the metridum foam or flex version. Now, metridum is a collagen elastic membrane matrix, and that is a biological in nature. It is different from biological temporizing matrix, that is Novosob. Now, this being a biological and biodegradable in nature, fills the wound cavity, and over a period of say 8 to 10 days, it will be gradually degraded, and it will be converted into a smooth granulation tissue. It is important to use this in highly exudating wound because even after debridement, this wound continue to discharge, which will be absorbed by this metridum matrix. As we have discussed earlier, it promotes the scaffold for cellular infiltration. Neoangiogenesis is there, improves the blood supply, delivery, improvement of delivery of antibiotics and nutrition, and it protects wound from the external contaminators, thereby reducing the risk of ultimately the rate of healing improves. The BTM or biological temporizing matrix is a synthetic thing. It it contains biodegradable polyurethane code and covered by a semi-permeable sealing membrane. It provides a template for neovascularization, fibroblast infiltrations, and like any other matrix, it allows vascular ingrowth and wound remodeling. The sealing membrane remove until when we remove, it prevents when sealing membrane is in place, it prevents the skin infection, wound infection, and when removed, it permits the application of skin graft over it. The advantage is that it allows the wound bed preparation. It reduces the infection. In fact, it can eliminate the wound infection risk. There is no risk of disease transmission. It improves the neodermis formation and it supports the healing in complex wounds. In cases of venous alarming because of chronic health inflammation, venous hypertension, there is a poor granulation tissue formation. BTM promotes the vascularization. It reduces the wound size and prevents the recurrent breakdown with the durable neodermis. Now here, I would like to add one thing that if required, the two techniques can be combined, like use of negative pressure wound therapy to prepare the bed, followed by coverage of the depth with the help of a biological temporizing matrix or a matridum, and then doing the skin graft. It is also useful in diabetic foot ulcers because of high infection risk and poor healing. We need some kind of substitute material in many cases. It improves the wound healing in ischemic and neuropathic ulcer. It provides possibility of early dermal coverage and reducing the possibility to exposure of bacteria. The chronic non-healing issues wound are covered with what is known as a non-viable granulation tissue. So we need to remove that first and then apply the BTM or Metridum to promote the faster the epithelialization and provide the neodermic quality. Is the case of pediatric cancer which presented to us in our KG Patel Children's Hospital with the pediatric oncology department. The child presented with a black blister and it suddenly increased in size with lot of tissue discretion. The diagnosis made was acute myeloid leukemia. So at no point of time the white cell count was going up more than 200 to 300. So the oncologist requested me to remove the dead tissue and provide something that can cover the wound and prevent it from infection. Since it is directly exposing to the bone, ideally we would have needed a flap to cover it, but that kind of reconstructive surgery was not possible under such circumstances. So we applied a biodegradable temporizing membrane, uh, and this is after 4 to 5 weeks. We can see that the proximal part of the wound has already started healing. The skin formation is there. The membrane has started lifting up from their side. Only the part where there was vein exposed, the membrane is still picking up. Uh, we had drilled the exposed bone so as to promote the vascularity and good granulation tissue formation from within the bone. So we expect that this is will ultimately heal. Final formal reconstructive surgery can be done when the child recovers from the leukemia, and we can think of major reconstructive surgery after chemotherapy is over. So this provides an important way of protecting the wound, protecting the secondary infection in the existing wound, and it's a good help in cases like this where the possibility of major surgery is very poor. Another case of diabetic foot amputation was done. The paid for after the amputation was not healing properly. So the debridement was done, matrix was applied, and then subsequently a flap cover was done. Again, a case of uh, diabetic foot, extensive infection after debridement, matrix was applied, and skin graft was applied over it. Another case of venous ulcer after vacuum assisted, that is negative pressure therapy, there was a granulation tissue. Then subsequently a matrix was applied because the tendon was exposed, and then skin grafting was done over it. The skin substitutes are the mm, like cultured embryo, mean cultured epithelial autograft, wherein we take a piece of patient's own skin and then culture the epidermis and use it over the matrix, that is whether it is biological or synthetic, and cover the wound. It's useful in the treatment of burns, ulcers, surgical wounds, and improve the healing and ultimate outcome in this situation. The benefit include it improves the cosmetic outcome, reduces recovery time in patients with wound. It also improves the possibility of survival of people with extensive burns like 70-80%. And there are potential risks included, which include infection, rejection by the body, or the scarring. Now, if we could consider the cost benefit analysis, all these synthetic materials are having very high initial cost. For example, 5 by 5 centimeter dermal matrix substitute would cost anywhere between 30 to 40,000, and a larger area are even more costly. But in case of like threatening situation, for example, somebody is having necrotizing fasciitis, after proper debridement, application of wax, and we can use the skin substitute, we can even save the life. The long-term value is very important because chronic wound is certainly a burden not only to the family but also to the healthcare system. So in the long run, as the usage improves, the cost will also come down. Healing outcome significantly improves because recurrent breakdown of the simple skin graft is very common because there is no dermis on there. When we use the dermal substitutes like regenerative matrices, Novosorb or Matriderm, it provides a scaffold on which we can put the skin graft. And these skin grafts are very stable as compared to the skin graft directly put on the wound. So, in that sense, ultimately, this will be a cost-effective way of treating the chronic wound. So, newer technologies like negative pressure wound therapy and dermal substitutes are transforming wound care, lead to better outcome, better aesthetic outcome of the chronic wound, and improve the quality of life of the patient. This is all I can say. Thank you so much.
Okay. Thank you, Dr. Hiren, for a very comprehensive talk. And it was very short.
I know.
So, but I see surgeons in the audience, so we'll have questions and comments from them. So, house is open for discussion now.
Kiran, regarding this negative pressure pump,
Yes, sir.
uh, pump comes with material
Everything is supplied by the company, sir.
company supplies the pump.
Yes, company supplies it. They charge a rent of about 400 rupees per day,
Okay.
and the dressing material would cost per dressing anywhere between 8 to 20,000, and we need to change the dressing every 4 days. On an average, 2 to 3 dressings are maximally required.
Yeah. So negative pressure pump is required for about 2 to 3 weeks.
2 to 3 dressings, so that is about 8 to 10 days because we
8 to
change
10
it
days.
every third day.
Right. And regarding this epidermal culture,
Yes, sir.
where it is done?
Sir, in India, it is done it in Pune, but it's not very well accepted because of the cost considerations. Because
Okay.
larger area will mean a lot of expense, anywhere between 1 to 5 lakhs. And epidermis alone will not provide a good stable scar. So we have to again use this dermal substitute as a scaffold and then put the graft epidermal culture cells over it. So it leads to a very expensive treatment. Compared to that, the use of homograft or skin
Yeah.
bank
Split
graft
skin
is
graft.
much
Yeah.
cheaper.
Yeah. Okay. Okay. Excellent case material and good results.
Thank you, sir.
Satish bhai, you have to unmute yourself.
Sorry. So these dress materials which you mentioned, no, synthetic and others, they can be used for any age group, right?
Any age group, sir, any age group. We use collagen for second degree burns. That
Hmm.
you are very well aware, but in pediatric patient now it is a routine that
Hmm.
instead of doing regular dressing, we use the collagen, which is a synthetic collagen sheet for all kind of scars, etc. So we don't have to do it repeatedly. But when there is a loss of dermis, we need to replace it with some skin substitute.
Why skin banking has not picked up?
So one thing is there are two things. The donation, organ donation itself is very thing. And the second thing is, sir, it's most of the time relatives do not find it so visually acceptable to, the harvesting of the skin from the deceased person.
Otherwise, according to you, it works well, right? If
It
it
works
is.
well. It works well. Works well.
The burns units have to take the lead in that matter. Well, burn patients are admitted and treated.
Hmm. Okay. Any more questions or comments?
पूछो ना
I think if there are no questions, I think we can end the session here. So thank you very much, Dr. Hiren, and thank you
Sir,
all
thank
for
you all
joining.
the attendees.
Thank you. So we meet next Saturday morning again. Thank you all. Thank you.